I want to thank you all for taking the time to come here. It's been a big interest of our board, several things about people who are unhoused. And so we thought rather than have people come in one at a time and that we'd try getting a panel together. Unfortunately, we don't have as many people here as we thought we would, but it is recorded so they can go back and listen to it. So it'll still be very helpful to everyone on the board and anyone else that wants to listen to it. So maybe I'll just, do we want to go around and say who's who here on the board? Okay, so I introduced myself, and would you like to go?
Yeah, I'm Randy Brown. I'm the liaison with legislature. Non-voting.
You can go ahead.
Hi, I'm Dr. Lena Zaff. I'm a psychologist. I'm integrated in primary care at Guthrie.
Hi, everybody. Travis Winter. I am one of the clinicians at Cornell we take care of the students at CAPS and a board member.
Yeah.
I'm Howard Reed. I'm a retired mental health center director from another state, a relatively new member of this board.
Would you like to introduce yourself?
Sure. Hi, I'm Janine Westcott. I'm a social worker and I'm the SPOA coordinator, Children's Single Point of Access for Tompkins County.
Great.
All right.
I think we have one more over here.
Hey, I'm Jade, a movement specialist at Bring It Home to the Casino Group. Today is our first day.
All right.
Yes, we're excited.
And you want to go?
I'm Karen Palazzo and I'm the administrative assistant. And I take the minutes and notes for the board meeting.
She does a whole lot for us. Okay, so maybe we should go into introductions of each of you and go through, and I believe you were sent in advance, like the kind of the general structure. I mean, we don't have to keep exactly to it, but you get a little time to introduce yourself and tell what your agency is about. And then when everyone's done that, we'll have some time to go through the questions that were sent. And you don't have to answer all of them. The ones that are relevant or seem important, you can answer. But I guess we'll start here.
Right. Hi, my name is Mike Ellis. I'm a clinical social worker at the Learning Web. I just started there in January, and I provide basically no barrier mental health services for youth who are engaged in the various programs at Learning Web.
And do you see unhoused youth?
Yeah.
Yeah.
Yes. Yeah, we do. Yep. They're in some state of unhoused, insecurely housed.
Yeah. Great.
Anthony Palangeli, I'm the Director of Youth Outreach at the Learning Web. At the Learning Web, we serve homeless youth in one of our programs. So we also have housing programs. We have a permanent supportive housing program, a transitional program as well. But we also provide services for youth who are currently experiencing homelessness. If it's in the street, couch surfing, we serve about 90 youth a year. We provide case management and life skills for all of those youth.
Welcome.
I'm Heather Bradley Geary. I'm with Vecino Group, and Vecino Group is a national supportive housing developer. So we develop housing throughout the nation to end homelessness. And here in Ithaca, we partner with TC Action, but we're the developer of Asteri Ithaca and then Ithaca Art House. So at each of those communities at Asteri, we have 40 units dedicated to folks exiting chronic homelessness. And then at Ithaca Art House, we have 40 units dedicated to transition age youth who are exiting homelessness. And then overall, just Vecino Group as a whole, we end homelessness for about 750 households every year across the nation.
Great, welcome. I didn't forget you, Liddy. I mean, I did until now, but now I remember. So just a minute.
I'm Danielle Harrington. I'm the executive director at Tompkins Community Action. We're an anti-poverty nonprofit. We respond to community needs as they change, but our core programs, we have an emergency food pantry, early Head Start and Head Start early education programs, and housing programs. We do rental assistance and we do supportive housing. We have 135 units of supportive housing across the city of Ithaca. and all serve people experiencing homelessness using the Continuum of Care's coordinated entry system. And then we weave our other services in for those households to make a maximum impact.
Thank you and welcome.
I'm Brian Coleman. I'm the New York State Director for St. John's Community Services. So here in Ithaca, St. John's is contracted by the county to operate the homeless shelter over on State Street. We also operate the Friendship Center daytime drop-in center, as well as a food pantry out of that facility. We also, here in the next month or so, we'll be bringing our Serenity House sober living program online for those who are reintegrating back into the community from treatment.
Great, come to you as well. And now, Liddy was supposed to do the intro to homelessness and its current state, but.
Okay, we're all experts. You've got a lovely panel here. And also it's very weird to be the only virtual member of a panel, so bear with me. My name is Liddy Barger. I use she, her pronouns. I'm the Director of Housing Initiatives at Human Services Coalition. We do many things, but the thing that brings me here is that we coordinate the Continuum of Care, which is a network of providers working together with the mission of seeing a community in which homelessness is rare, brief, and one time. I do have like a 4-slide long presentation for level setting in terms of need, if people want to see my 4 slides. Would you? Yeah.
Sure. And when you speak, could you either speak up or speak closer to your microphone?
Yes, I can try.
It's a
Is
little
that
hard to hear you?
Can you hear me? Okay, I'll see what I can do. I'll talk loud. All right. So are there other, did everybody on the panel get introduced?
Yes.
Okay. So I wanted to just give some baseline information about the level of need that we see in our system. And so I just put together, literally, it's 4 slides about our homeless response system. And I am going to share my screen. All right. Y'all can see my screen. Yeah?
Yes. Yes.
Great. So I just said this already, the mission of the Continuum of Care. We're a local planning network. We have private, not-for-profit, for-profit, local community members all working together around this mission of making homelessness rare, brief, and one time in Tompkins County. We do that through kind of a bunch of activities. But the 3 main ways that gets done is we work to organize a community-wide effort to prevent and end homelessness. We do this partially by monitoring data, which is what I'm going to talk about in the next slide. We're also a funder, so we provide funding to not-for-profit agencies that are working to end homelessness, primarily in permanent supportive housing projects, but there are some other ways that we bring some funding into the community. The Continuum of Care is the mechanism through which HUD homeless response system dollars come into communities. Our funding cycle is now open, so if people want to hear more about what that looks like, I'm happy to talk about it offline. And then we promote access to supportive services and housing. We primarily do that through our coordinated entry system, but there are some other ways that we try to do that. We don't really need to go through this whole slide, but a lot of times people hear that making sure homelessness is rare, brief, and one time. And I like to add just a little more detail to what that means. What would it mean for homelessness to be rare? What does it mean for it to be brief, one time? These are all system performance metrics that we monitor using our homeless management information system. And these are sort of benchmark goals that we're working towards as a community in this goal of ending homelessness. You can take a look at another time for that. So this is from last year's, this is a whole year of people in our system. Just a quick snapshot. So 599 unique individuals. Those are children, young adults, and adults all together. We're served with emergency shelter. So it's not our full, it's not the full scope of people experiencing homelessness, because we are missing some data around unsheltered homelessness for our community because we don't have a traditional street outreach project. But those are all 599 people entered our emergency shelter in 2023. Through only 31% of them had a positive exit to permanent housing. So we want to increase that number, right? Just under 30% of those folks who did exit to a permanent destination in our system in 2023 are returning to homelessness. So they had an experience of homelessness within the last 2 years, became housed, and are now coming back. This metric here, 94 days, this is one that really kills me a little bit. So HUD and the others would agree that industry, the standard would be about 40 days is really the longest that a person should be in an emergency shelter setting. And here in Tompkins County in 2023, our average was 94 days. And that speaks to our housing availability, the quality of housing, and also financial resources to support people into those housing destinations. We have an overrepresentation of BIPOC folks in our system, both in the shelter and in our unsheltered locations. We have more BIPOC folks than would make sense for the composition of our community. So this is the slide. I just put this together today, so I'm sorry it's a little wacky. But these are the mental health and health conditions that people are self-reporting when they're coming into shelter. So the universe is 599 people for this slide, just so you know. I realize I should have put that on there. And it's all self-report. Some people are self-reporting multiple conditions. And I looked at 2022 as well using the same model, and it was almost identical. I think there was a slightly lower mental health disorder and a slightly higher substance use disorder in 2022, but this is pretty standard for what the conditions that people who are entering our emergency shelter are reporting experiencing. So just under 40% of folks are reporting that they have at least one mental health disorder. 26% have come in saying that they have substance use disorder. Our database actually breaks substance use disorder into alcohol use, drug use, or drug and alcohol use together. And that's the combination of all of that data. That's each of those categories combined. So if somebody said they had alcohol use disorder, I did include them in that substance use disorder number. Chronic health condition, just under 15%. 6% of folks are reporting that they have a developmental disability. And if I'm going to be perfectly honest, I think that's lower than the number of people who probably have a previous diagnosis of a developmental disability. I think that is lower than what we would actually see in the system. That's our baseline of what people are saying their health and mental health conditions are coming into our system. I wanted to stick this slide in here just to remember that 40% of the people in our emergency shelter system are survivors of domestic violence. And of that 40%, 41% of them were currently fleeing, which means that they are leaving a domestic violence situation imminently within the last, say, 90 days. That is an alarming statistic to me, and one that I hope we can work on together as a community. These are our current offerings. These are the places that people can be referred using coordinated entry into. And this is a slide from another presentation that actually had 2023 projects before it, and then these 2024 ones, so we could see that we're sort of at capacity in our projects. We're going to need more projects to be able to meet the need of people in our system. But we have people here from all of these projects, except maybe a couple of the transitional ones, and I'm sure they'll be happy to tell you about all their great work. I just wanted to give people a sense of what the scope was. So there's about 200, I think it's 204 units of permanent supportive housing in Tompkins County that folks who are experiencing homelessness and have gone through coordinated entry assessment can be referred to. And right now, I think we have 2 vacancies and maybe less, because this slide was from a couple weeks ago. Just to give a sense of the bottleneck in our system. And that's literally it. Those are my 4 slides. Thank you.
Thanks so much, Liddy. Does anyone have any brief questions for Liddy? Not right now? Great. And I made a mistake and forgot Jessica Connor and Larry Roberts, who are both on our board. My bad to forget that Larry is up there. Larry, do you want to introduce yourself?
I'm Larry Roberts. In addition to serving on the board, I'm the chair of the mental health subcommittee.
Thanks. Jessica?
I'm Jessica Connor. I'm a psychologist over at Northeast Pediatrics, and I am on the board and I'm on the mental health subcommittee.
Thank you.
Liddy, would you be willing to share those slides later with us so we'll have them?
Yep, I can send them to Karen or Harmony or whoever.
Thank you.
Yeah.
Liddy, we do have someone here who has a question. Randy Brown.
Yes, Liddy, this is Randy Brown. How are you?
Good, how are you?
So on your slide with the data on the 599, I think, homeless people, how is that data collected? Is that through the Human Service Coalition, through all the various entities? How do you get that data?
Yeah, that's a good question. Thanks. So all continuums of care everywhere in the United States, but here as well, are required to use what's called a database called a homeless management information system. And any provider who is offering services to people experiencing homelessness, specifically like overnight, like a bed and a place to sleep kind of services, are expected to enter data into that system. And the continuum of care monitors it, does data reporting, sort of has the full bird's eye view of all of that data that's going into our HMIS, and then we can report it out however as needed. But it's a database called HMIS. I think there's several HMIS users there in the room with you.
Thank you.
Who's an HMIS user? Most of you. Well, thanks again, Liddy. Stick around if you'd like to. So now we can get into people talking about the questions that you were given. You guys were pretty brief with your agencies, so you might want to describe a little bit more if it's relevant to what you're going to say. And I don't have the questions in front of me. I'm sorry. Do you have them? So, anyways, we should probably just get started because we've already gotten a little behind. So maybe we'll start with you. We'll start at the side this time. Maybe you could say the question you're addressing. As I said, you don't have to address them all. And are you timing it so that everybody?
Yeah,
Thank you.
10 minutes each.
We're just doing it so everybody gets.
We want you to all get a chance to talk.
Right. So one of the questions that was posed was, do we plan to start or end any services in the next year? And so, certainly, as I mentioned, our Serenity House project is going to be coming online here in the next month. And so that will be coming open. We are also in the process of pursuing outpatient substance use services. We're seeking approval to provide Medicaid waiver services to individuals with traumatic brain injury, as well as services for individuals who qualify for nursing home transition and diversion waiver services as well. So, those we're hoping to bring online here this fall. And then also, we're actively in the process of, if there was an opportunity for us to pursue licensure for services for individuals with intellectual and developmental disabilities, we would also pursue that, because that is something that within the St. John's organization, we have a significant amount of experience with in the other states that we operate in outside of New York. Want me to answer all the questions now? Or do we want to, okay. So the other question that was asked was 2 to 3 challenges that we are facing within our program. And certainly, as was pointed out on these slides, access to mental health and substance use services is a challenge for us. For the last several years, we have had a clinical case manager position posted. We've adjusted the salary a few times on that and unfortunately have not been successful in filling that position. So we recognize that is a need. The other item that we see a lot of is pets. And so a lot of people coming in with dogs, and when you get a lot of dogs in a confined space, and then obviously trying to make sure that from a health standpoint, we're helping our guests with getting their, when I refer to guests, I'm talking about the clients, the individuals that we serve. So, you know, helping them to access healthcare for their pets if needed, food for their pets, things of that nature, as well as storage of personal belongings. So when they come in, we do, because of space confines within the shelter, allow each guest to have 2 bins of personal items there. And then we have offsite storage that we will provide and hold on to their items. It's challenging when, we certainly don't want to get rid of somebody's items, but then we have space limited, as far as how much we can maintain from a storage standpoint. And then I think, really one of the challenges that we're seeing more frequently is just the level of care of people who are coming to the shelter. So I can give an example of an individual with intellectual and developmental disabilities was at home with family. Behaviors became too challenging. Parents said, we don't know what else to do. And so they brought this person to us. And so we've been working with this individual for several months now as part of a group of people that's trying to help them. So DSS, as well as community advocates and some other service providers, really to get everything put together that's needed to get them through the OPWDD front door process. But it's a challenge, and it's not housing focused, but it's the right thing for this individual. Similarly, this last Friday, we had a person in their late 60s who was dropped off at our shelter in a wheelchair. And so, we're not a skilled nursing facility, but meanwhile, it's 7 o'clock at night on a Friday, and so we took care of the person over the weekend, and then this morning took them to the DSS, so I mean, those are the kind of things that we're seeing, unfortunately, more frequently, and trying to figure out how to navigate those things. I think as far as ideas for the last question was ideas for overcoming these challenges, I think I come from a community action agency background, and so collaboration is significant. And so I met with Danielle last week, and I'm hoping to meet with the folks from Learning Web here in the weeks to come, because we can't be a one-stop shop. And so bringing in additional resources into the shelter is going to be significant for us as far as really getting to, provide the supports that are needed for folks. So there's 5 minutes to spare. That's all I have. Sorry.
Oh, okay. Very efficient with it. Okay, so maybe I'll take a minute just to read off what the questions are so people have that context. To provide a brief summary of the services that are provided to unhoused people for each of you. And do you plan to start or end any services in the next year? Third question is, what are 2 to 3 biggest challenges your team faces when working toward housing for unhoused people? And the fourth question is, do you have any ideas that might overcome these challenges? So,
I guess sorry.
Go ahead.
I was just gonna say, I think the only thing I didn't speak to is we do not intend on ending any services.
What did you say?
We don't intend to end any services. So
Oh,
that was,
okay.
I didn't speak to that.
That's great. Well, you certainly sounded like you're trying to broaden your scope. So Danielle, do you want to go next?
Sure. So at Tompkins Community Action, I mentioned briefly, we have our food pantry and we have our Head Start programs. Families experiencing homelessness with young children are categorically eligible for Head Start. So that's one way that we kind of provide some support. But mostly it's in our housing programs. We have Housing Choice Voucher Rental Assistance Program that's more commonly known as the Section 8 program. We have about 1,200 vouchers in the community across the county. So we help, the waiting list is very long, but there is a homeless preference where if you're unhoused when you apply, it puts you at a better advantage point of the waiting list time. However, the problem is you generally don't have a reliable waiting or a mailing address. So that becomes a barrier down the road. But like Brian was saying, we're trying to create better connections so that less of those folks fall through those cracks. Our most probably influential program when it comes to unhoused folks is our permanent supportive housing program. We had the list on the board. Just briefly, I said we had 135 units. This is permanent supportive housing. All residents have a 12-month lease. They have the same tenant protections as any other renter in the community. There is rental subsidy attached based on their income. We serve the most vulnerable through the coordinated entry process. Across all of our programs, we use a housing first philosophy and a harm reduction approach. So the folks in our programs have diagnosed and undiagnosed mental health disorders, substance use. With our programming, you're not required to have sober time or be in a treatment plan because we believe that you have a right to housing. And we can't ask you to come to us as a person experiencing homelessness with a disabling condition and then tell you that you need to change everything because you have that disabling condition. So we've fully adapted the housing first approach. We have kind of two different sets of population is kind of the word that's used. For our youth housing, that's 18 to 25-year-olds, single individuals, couples, young families who are pregnant or parenting. We have 40 units at Art House, 23 units at our Amici House, 6 units at Corn Street. So that gives us 69 units where we're just working with young people. And then for our chronic homeless sites, we have our 40 at Asteri, Heather mentioned, 12 rooms at Chartwell House, and 14 apartments at Magnolia House, which gives us 66 units for chronic homeless. So it's almost an even split. But our approach to providing the services is really individualized. It's one-to-one. Each resident is assigned a staff coordinator that partners with that household to do goal planning, to navigate services through the Department of Social Services, to apply for a photo ID, get your birth certificate and social security card that opens the doors to a bunch of other things. We're really big on housing stability. So it's about coming inside, creating an environment that feels safe for you, building community within the building that you live in, and building community out in the world so that you can feel comfortable going to school, going to work, volunteering. There's a lot of misconceptions about what's actually happening. But those are the things that the staff support with either daily check-ins, weekly check-ins based on what the resident needs. So it's more or less depending on what's going on in life. And life is hard for everybody right now. So living in poverty is even harder. So we do our best to be kind, treat people like people. Our staff may have backgrounds in social work and things like that, but we are not licensed therapists or CASACs. So we rely on our community partners to really partner with us to provide those supports. We bring a lot of services into the buildings that we use. So we partner with Reach Medical, Learning Web, and a bunch of other organizations to kind of bring people together and move people forward. Let's see, next. Do we plan to start or end any services in the next year? We don't have any big plans to start anything. We certainly don't intend on ending anything, but we're in the middle of our community needs assessment and creating our strategic plan for the next few years. So as a community action agency, we respond to needs as they change. So we might not have anything in the hopper today, and next week Liddy might call me with something and we're doing something new. So the challenges. I started to write a list and then it got depressing. So like Brian said, there's not enough substance treatment or mental health supports available. In a perfect world, I would love for things to be on demand, because when somebody's ready to make a change, if you can do it in the moment, it moves forward smoothly. When you have to go to an appointment and then go to another appointment in a couple of days and another appointment in a couple of days, you lose people, life happens. And sometimes that is the biggest barrier. The folks we serve are vulnerable to victimization, especially once we bring them into their own housing. They have family and friends who might be in other, less desirable situations. They show up at the door. It's really hard to turn family and friends away, no matter who you are. So we try to build some safety nets in to help people remain as safe as possible. And then we also have the challenge of community perception. There are stereotypes about people living in poverty, people's stigma for the unhoused, fear, all of those things. And that's more than 2 or 3, but that's what I brought. But to overcome those challenges, like Brian, we're always trying to continue to strengthen our community partnerships. We keep looking for out-of-the-box solutions to system failures. We always are doing continuous program improvement for our own programs, checking in with residents, doing surveys, making sure that what we're offering is actually what people want and need. We're always doing ongoing staff training. We're very mindful of staff wellness. It's really challenging work to work in all the negative stuff that I just mentioned every single day. Sometimes bad things happen to the people that we're working with. And so there's loss and grief, and it's about supporting staff in that way. And then they in turn support each other. So I think that is something that we're kind of getting really good at. And then what I think the last thing that we're going to do is really do a better job expressing our successes in the press, on social media. It doesn't take long to scroll through and see all the problems, but we're not seeing that, out of the 40 units that we're serving, 5 are really struggling, but the other 35 are really killing it out there and doing, more positive things. So we're going to do a better job at working on that. And that's all I have.
Great.
Not as good as Brian. I only have 1 minute and 10 seconds.
That was very interesting.
You want me to go? Okay. I didn't know where, I was like, questions?
We were going to do that at the end.
Okay, perfect. So pretty much ditto everything that Danielle said. We're honored to partner with TC Action, but I would just a little bit more about Vecino Group. We believe housing is a human right, and that you shouldn't put barriers up for folks to get into housing. So we are also housing first. And we believe, I say this a lot, but actually ending homelessness is really easy. We need to provide people housing. it's, you know, we make it very complicated in our country and around our policies about how do you end homelessness. It's actually very simple. We need more units of housing. I'm not saying we can just put people in units. We have to bring in all the services to help people stay housed, but we have to have more permanent units. We can't end homelessness in our country until we talk about the lack of permanent affordable units that we have. So that's what Vecino believes in doing. That's what we believe our lane is permanent housing. We believe that that's how we're going to end homelessness in our country. So most of our housing communities are integrated, just like Ithaca Art House and Asteri, where it's an affordable housing community and a percentage of the units are set aside to serve folks that are exiting different populations of homelessness. And so integrated is usually what we do at Vecino. We do have some 100% permanent supportive housing communities, not here in Ithaca though. And then just as far as what we see, where our funding's at, y'all are stuck with us for a really long time. So both of our communities are funded, through low-income housing tax credits and 4% bonds through HCR. Those are at least a 15-year compliance period, usually longer. So we're here to stay. We're not going anywhere. And hopefully if Danielle doesn't get rid of us, we'll continue to build housing together. So we're not going anywhere. And then I would say challenges, Danielle mentioned this a little bit too, but for us, one of the hardest things when we're serving folks that are exiting chronic homelessness, sometimes the folks like at Asteri, we have folks that have been on the street for 13 to 15 years. And then you bring somebody into a unit and you're like, all right. I mean, not that TC Action does that because they provide all the services, but that's scary. And we don't acknowledge that, right? Like this is a hard thing to do, to go into permanent housing. You don't know how to live in permanent housing. And so that first 90 days is just so critical that we're serving folks during that time to make sure that we're getting them all the things that they need to be successful in housing, because the last thing we want to do is just cycle people back into homelessness. So I would say that that's a big piece. And this isn't just specific to Ithaca. The general community and the stigma that exists around homelessness is just kind of unacceptable to me. And so just educating, it is unacceptable. It is not kind of, it is unacceptable. So just educating folks on, you know, people aren't unhoused or homeless because of something they, you know, this constant, like it's something they did wrong. They're lazy. They need to get a job. Like, we really need to work hard to get rid of that stigma. And I'm looking at myself too. You know, as a community, we need to do that work. And so I would say for us at Asteri, that's been really difficult. And I can say that, I don't live in this community. Poor Danielle takes all the shots for us. But yeah, that's been really difficult. The community and anything that goes wrong, even close to Asteri, TC Action, Vecino, it's your fault. And so just educating folks on what it means to be homeless and what it means to exit homelessness, I think is really important. And then, like I said, just we need to create more units. Solutions. Well, I'm super excited that Liddy and her team provided us a grant so that we could hire Jade to be our move-in specialist. So really looking at critical time intervention, not to get too social worky, but that like when somebody moves in, that critical time intervention of 90 days of what can we do to help this person stay housed, I think is a solution. We need to allow people to transition out of homelessness. We unfortunately, because Asteri is a high rise, it wasn't safe to do at Asteri. But in a lot of our other communities where we serve folks that are exiting chronic homelessness, we have an outdoor courtyard where people transition out of homelessness. So they have a unit, but it might be really terrifying and traumatic to sleep in their unit the first couple months, maybe the first 6 months. And so they can sleep out in our courtyard. And so just adjusting, and sometimes with pets too, like, like Brian was saying, like pets can be out there. So I think we need to allow people to transition and give people time to do that, still in permanent housing. And then service, we have to provide service. And honestly, the eShy program in New York is, I will say, best practices in the whole nation. And I feel like I can say that because I get to work nationally. We don't have anything like the eShy program anywhere else in the country, which is rental assistance and services in permanent housing. That's how we're lucky to have TC Action on board with us to pay for their services, staff, and the rental assistance for all the units. We don't have that in any other part of the country. And so that we have that in New York, I think is huge, and honestly what we should be doing nationwide. And then, yeah, I would just say educating the community is a lot of the work that we need to do up front, and then continue, like Danielle was saying, like continue that work after too.
Great, thank you.
All right. So at the Learning Web, we do have housing. We have 9 transitional apartments for youth ages 16 to 24. Youth can stay for 12 to 18 months in those apartments. We provide all the utilities and all of the rental assistance for those units. We have 16 permanent supportive housing units for youth ages 18 to 24. Those youth are in there permanently. And we also have 7 eShy units that we do in collaboration with Salvation Army. All of our units are scattered site. We don't do any residential housing. We have all of our youth are in their own apartments scattered throughout Tompkins County. We have some in Enfield. We have a couple in Brookendale, but most of them are located within the city limits. Each of those youth are provided with a case manager. The case manager will focus on a couple main subjects with our youth: employment, education, addressing physical or mental health needs or addiction recovery services, or parenting. We have also a parenting program at the Learning Web, where we have about 20 families who are now enrolled, and they receive parent classes, case management as well, and some money for concrete needs. We provide diapers, we provide cribs, really anything that they may need. We also started our own mental health services with Mike over here, who started this year, where our youth have no barrier access to mental health support. So we cover all of the costs. So there's no insurance, nothing needed. You can come in and ask for an appointment, and Mike will generally fit anybody in. Within the past year and a half, we've started a bunch of new services. Our permanent supportive housing program is fairly new. We've had it going for about almost a year now, as well as we have about 5 more transitional units that are going to be online starting in October. We're not ending any services, and we hope not to as well, depending on funding. And then we also have case management services for youth who are not in any of our housing programs. So a lot of our youth come through our program to enter coordinated entry. We give them an assessment and put them on the list. And if they're not in one of our housing programs, they may eventually make it to a TCA unit in Amici or Art House, or we may be able to secure a different type of voucher for them to live independently. But even after they are housed in TCA or on their own, they still receive case management services as needed. We have some people who stay engaged a couple times a week, and then at minimum, we'll check in once a month. All of our youth who transition out of our housing program still receive aftercare. It's not like once you leave our housing program, we're done with you. You can continue with us up until the age of 25. 2 problems that I see facing our youth is there is no youth shelter. If you are a youth under the age of 21, you cannot enter our shelter without your parents having to pay child support for you. So a lot of the times our youth go to DSS to try to get into the shelter, and the first call that DSS makes is to the parent, and they explain it to the parent that if your youth enters the shelter today, we are going to go after you for child support. Can they come home? Even if it's a really toxic, terrible situation, our youth parents will still say yes, send them home, just for the fear of having to pay child support. So getting a youth into the shelter under the age of 21 is practically impossible. And if you're under the age of 18, you can. It's not even considered. You have to be above the age of 18. So it's always been a dream of the youth services here in Tompkins County. I think it's brought up at least once a year by a different agency, and it has not happened. Another one is the rental market here in Tompkins County. I think everyone knows how difficult it is to find a place to live, especially when you have youth who do not have any rental history and don't have income history like an adult would, or the income that an adult normally would. It's impossible to find to rent a place to live. And also we face stigma as well as our house, but it's just with the word homeless. When we are trying to secure apartments for our youth and our programs are on their own, once they hear the word homeless, that's a deal breaker. They attribute a lot of our youth to, when you hear the word homeless, to street homeless or the jungle, but our youth really aren't really there as much as adult population. I would say 90% of our youth are couch surfing at TCA's, Amici, or our house. I always say they basically solve street homelessness for our youth, because all of the youth that are in those programs were homeless at one point and they know what it's like. So it's not a problem for them to just say, yeah, come sleep on our couch. Luckily, we are able to categorize couch surfing as homeless here in Tompkins County. So that allows a lot of our youth to be eligible for our services. Some ideas to fix it, some rental assistance that's solely for youth. I know we have had conversations recently about doing something just solely for youth. It's intimidating for our youth to go to DSS. And like I said, if they're under the age of 21 to receive any assistance, go to Section 8. But if we could have like a low barrier rental assistance program for you, that would be great, where we could handle it. Someone could handle it that has some actual familiarity with the youth population here in Tompkins County. And more housing. I think the lack of housing in Ithaca is something that's always going to keep us in business, unfortunately. But for our youth to be able to find an apartment that's fairly priced is practically impossible. And then I'll let Mike talk a little bit about the Learning Web and his role.
Okay. Yeah, so I started Learning Web in January. I would say we're still sort of in pilot mode, but the main purpose of my being there is to provide 14 hours of mental health services for the youth in the various programs. And I also provide training and support for the staff at Learning Web, which is a key piece of the work. And that includes both training in different mental health topics for their work with youth, but also for them as an anti-burnout initiative, and because this is difficult work that we do, and it's good to talk about it. So I'm there for that as well. And I would say so far at any given time, I see between 16 and 20 youth, carry them on my caseload. It's a weird thing in that context, but for all intents and purposes, you understand what I mean. They are between the ages of 18 and 25. And I guess we focus on some of the systemic challenges. So I'll focus on some of the mental health challenges that get in the way or that are difficult in getting housed or remaining housed. And I think what it comes down to a lot of is the word relationships. It starts with their relationship with themselves and their family of origin. And they're at an age, that critical age between 18 and 25, where they are unraveling the wounds of childhood and trying to face the stressful world of adulthood. And all of the youth that I see, their relationship with themselves has been damaged along the way. So helping them learn basic self-care, and also including, and not just including, but emphasizing boundaries as part of self-care. As Liddy's slide pointed out, a lot of our youth have experienced domestic violence or are currently experiencing domestic violence in their relationships. So how to feel like they have the skill to create safety in their relationships, how to draw lines where they need to draw lines, that also plays out in addiction and substance use. Because part of, if somebody is looking to get sober, they have to set boundaries, hard boundaries in their life with other people who may still be using or encouraging them to use. And then the other piece of that is learning distress tolerance and learning how to make different choices. Their lives are very, very stressful. They come from stressful lives growing up, and their lives being insecurely housed or unhoused, trying to hold a job where, talk about relationships. There's coworker relationships, supervisor relationships. If they burn a bridge, they may not get another opportunity there, depending on who the person is. That may be one strike and you're out. They, get upset one time, lose it. And then there's a very fragile set of dominoes there, right? So if they lose employment, then they may lose their car, they may lose a whole bunch of things that are being held together, in a very kind of fragile way. So a lot of the work that I do is about helping them reclaim, first of all, understand their lives. A lot of them, they've been living in such survival mode, they haven't had a chance to just sit and make sense of it all. So just having the opportunity to talk about it with somebody that can help them understand what they've been through, and that a lot of the choices that they make are driven by the trauma that they've experienced, and understanding that the stigma that's been dumped on them for not succeeding in one way or another, that there are compelling reasons for that they didn't ask for, that they didn't do, and that their work is to learn how to heal from that and how to make different choices. So that's so those are some of the challenge, some of the mental health challenges, and of course access to services is huge, and I feel like it almost goes without saying, but that's why I chose to be there, and I'm excited about creating this model with Learning Web, because it's a very flexible model. I understand this because I've been working with unhoused youth for close to a decade at this point, and I know that one of the biggest barriers that they have is, first of all, getting in someplace, because a lot of times the waiting lists are long, but also being able to keep to a schedule of appointments is very difficult. And so being in the building where they're already coming to get other services makes that easier. Getting a warm introduction from somebody that they're already working with, their case manager, somebody that knows them well and that they trust, that can vouch for them to at least give me a 10-minute shot, come in, meet with me, say hello, see how vibe feels. You can't do that in the traditional clinical settings that I come from. It's a 1 o'clock appointment. It's a 1 o'clock appointment. There's someone coming at 2. So we don't have that kind of flexibility of just an informal, just feel this out, see what you think about talking to this person. And that seems to be something that's really working well. I'm also make myself available by video and by phone. If somebody just can't get in that morning, or that time that they're supposed to come in, I try to meet them where they are as often as possible. So the big sort of systemic barriers are lower because there's no payment, there's no insurance, but also some of the I guess I'll say smaller logistical barriers are less present as well, because they have a lot of different ways they can access me at different times. It's somewhere between a drop-in center and a traditional counseling model. And I would say, as far as ideas that might help, one thing we don't have that I wish they had is easy access to psychiatry, because I can't prescribe. So a lot of them would do well to at least talk about getting on some medicine that will help stabilize their mood, or help relieve some of their anxiety and depression. And I can't do that for them. So it's still about trying to get them into a system where they can see a psychiatrist. And I think that this model is working. So I would say that if it's something that could be adopted wherever possible, wherever people whose lives are so unpredictable can have a more flexible access to a service, I think it's a great thing.
Thank you so much. So now I think that's everybody, right? Yeah. So now we can do some questions from the board or other people? I guess there's just one other person. So who wants to start? I'll start.
So first of all, I want to say thank you for mentioning pets. You know, that's a very important, helpful thing for people in mental health, of course, you know, being a very important protective factor. So I appreciate that that's being considered. The other thing I want to kind of bring back up that we kind of started with, and I want to kind of bring it full circle, is the domestic violence situation. So obviously there are a very limited number of programs and resources that are specific to that. So I'm curious, I know you touched on it, but wondering specifically with living arrangements, when people are coming from a domestic violence situation and they have somebody who is a substance user next door and their abuser was a substance user or things like that, and the re-traumatization and those kind of things. So I'm curious as to when knowing that 40% of the people that are coming into these shelters are in that situation, are these factors being taken into consideration? And if so, how is that kind of playing into their placement, the supports they're given, knowing that this is such a big piece of the puzzle and there's so much risk. And that is why people go back on average 7 times before they leave for good.
Yeah, so I think I could speak to that.
Yeah,
so so when somebody comes into the shelter part of the intake process, we're learning from them what their story is, you know, and part of that is identifying what the best placement option would be for them as well. You know, certainly, you know, recognizing that, so our shelter capacity on State Street itself is relatively limited. So we do utilize a lot of hotel partners across the community as well. And so, you know, so that is evaluated and that is assessed as we're going through those placement options. And so then from there we look at, okay, where's the best placement that we can put this person for their well-being, and then their case manager follows up with them as well to start working on what is going to be their kind of long-term solution. So take care of the immediate issue, but then switch to the long-term as well.
I can add a little bit to that. When we have openings in our permanent supportive housing, we use the coordinated entry system, but it's up to the person's choice. We have this place at Magnolia. I'm sorry, I don't feel comfortable living there. Okay, we're going to reach out to you again in the future and see if something else will work. You know, if we have somebody come into one of our programs and they've shared the history with us, then we do our best to keep them connected to the advocacy center or whatever therapeutic relationship they have. We help with legal avenues. And we just try to keep a lookout and keep that wraparound support as much as we can. And then we honor that they have choices, that they get to live their life. They don't have to give up their, you know, personal freedoms because they've entered into a program with us. So we do a lot of staff training, but ultimately our programs are so small. If we have one opening on the 3rd floor, that's that. And we leave the choice up to the person moving in. But we don't remove their future options if they say, no, not right now.
Yeah, you else want to add anything? Okay.
Hi. It sounds like you know one another's programs very well and you work well together. And with this, you know, with the people that you're working with, that's so important that there be no wrong door. You know, several of you have mentioned a major challenge being access to mental health and substance abuse services. And I wondered if you could talk a little bit more specifically about that. What kind of specific mental health and substance abuse services you find are gaps that that individuals you're serving are not getting access to, and that's creating a significant problem. You mentioned psychiatry as being a particular gap that you see, but I wondered if the rest of you could talk a little bit more about that.
I mean, accessing mental health services or psychiatry in Tompkins County for our youth is practically impossible. I mean, it does require a little bit of work from them, but generally I don't know how TCMH is doing now with it, but I know before you would have your intake and then you'd be lucky to hear from someone in a month. I would say out of the 90 youth that we serve, probably only 3 or 4 see somebody privately. If it's insurance or for something like that, just access to is pretty tough.
Yeah, we see insurance barriers, so we help navigate that. It's about finding a provider that works for you. Many of our folks, I think Mike mentioned, it's hard to keep a schedule. And if you miss an appointment, you miss 2 appointments, then you go back to the beginning of the whole process again. And there's no really continuity. And then emergency crisis is through, law enforcement, Cougar Medical, and a lot of our folks have trauma from all of those systems. So we have to try to rebuild relationships and, go along with people to their first intake meeting and do those kind of things. But I also don't think there's enough providers available.
And I think for addiction recovery services, CARS is in the middle of Plain Street. I mean, it's at State and Plain, and a lot of our youth going down there, you're going to see someone you knew, someone you may have used with before. You could easily have a bad experience. Our youth don't like traveling down the CARS. I mean, we will go with them to an intake, but after that, you're going to see somebody that you know or someone you potentially had a bad experience with. I mean, CARS is in the middle of the action for the most part. It's easy to be triggered by going down to State and Plain these days.
Makes it complicated when you're trying to avoid people, places, and things.
Right.
Yeah, Stu.
Piggyback the CARS, we have the council that makes it even tougher. What have you mentioned? And never heard. So you tell me a little bit more about eShy. New York City. Sound good. What is it good for?
Sure. So eShy stands for Empire State Supportive Housing Initiative. It's a funding source through the state of New York where developers partner with service providers to bring supports into the project for whatever target population is identified. They have to be homeless, partnership, but it can look a variety of different ways. The flexibility is the key to what makes it so good. And then partners, we can do it. So at Tompkins Community Action has eShy funding at Amici House, which we own and operate nuts to bolts. And then we have eShy funding at Art House and Asteri, where we partner with Sino to provide services in their buildings amidst the rest of their residents. But it's on a funding cycle. The contracts are 5 years at a time with annual renewals. It's one of the only funding sources that gives a 2% increase every year, which is always helpful, especially when we're very used to flat funded or decreases. Heather, what am I missing? Any of you guys have?
Yeah, we use it. So Vecino uses the eShy program throughout the state. We have several eShy grants, and it comes out usually in October is when the application comes out. It does come out yearly. To apply for new projects, and then it's ongoing after that. It truly is, in my opinion, best practices across the nation.
Federal?
It's state funding. Yeah.
Did you have a
I
question?
do. In the data Liddy provided, it said about 1/3 of the homeless people have physical ailments or disabilities. And there's not, I think I heard that there's not really a good system for supporting them at a homeless shelter anyways. Should there be a separate solution for them?
And I don't know what a separate solution off the top of my head.
I mean, separate housing, I mean, a different environment, I mean.
Yeah, I mean, certainly, so in the examples the 2 examples that I shared, so in one situation you have, really with both of them, when you're talking about the vulnerability that was expressed, the risk of them being manipulated or taken advantage of is significantly higher. Or in the instance of the person who was dropped off there, last week that I was sharing about where physically, limitations on, we're not equipped for, somebody who isn't able to transfer themselves and, things of that nature. And so, I don't know what a facility looks like for those folks. And certainly for us, we're helpers at heart. And so we want to help this person, and, taking them to the hospital and dropping them off doesn't feel like the right answer. Right. And so, yeah, I don't have a direct answer for your question, because I don't know what a facility like that would really
I asked that question
look like.
because there were homes that New York State owned in Tompkins County that were for disabled people or people that need more constant care. And there's 5 of them in Tompkins County. They closed 4. And there's one left on Lincoln Street that's in the process of closing. And there's 40 beds, and these are nice buildings. So my thought is it's a shame that these, and they're closed, they're boarded up. I mean, there's a really nice one where the armory is on that road there off, and it just sits there empty. So I'm just trying to think if there's we have buildings now, we need the people to probably manage them and provide services. But as you talk about housing, could be a youth building, there could be whatever, right? So and then Tompkins County doesn't have a place to put youth if they have to go to jail. Again, same situation. They're shipping them out of the community. So I'm just trying to think of that.
I don't want to miss
Hey, I'm
whether.
here. Hold on, I have something I want to add. I'm sorry, I jumped in on this one. There's a slide that I was going to put in this presentation and I didn't, but it has come to my mind and I want to talk about it a little bit. So another thing that we know from our data is that the first experience of homelessness somebody has, they are likely to have 0 or 1 physical, mental health, or substance use disability factors. And by the 4th time, that same person enters the shelter again. I don't have the slide in front of me, so I'm not going to say the number, but it has basically tripled, right? So at the first episode of that's because homelessness is incredibly traumatic. So at the first episode of homelessness, somebody may not be reporting a physical disability or a mental health disability, but generally, if they have cycled through enough times, by the time they get to that 4th episode of homelessness, they have both physical and mental health disabilities that they themselves are self-reporting, which is an indicator to me that we need to interrupt that cycle before people are, harmed by the trauma and the badness of experience, the victimization, all of those things that go along with experiencing homelessness. And so anything that works to interrupt or be an intervention as early as possible in those episodes of homelessness will reduce the number of people who experience physical disabilities in the future, because they're not all fixed, right? Some of those are folks who had catastrophic injury or illness during the time that they experienced homelessness that could have been avoided if they were in a housing situation. So I just had to jump in and say that, because but we're talking about it as if people's disabilities are fixed at all times, like a lifetime. But really people are developing new and worsening disabilities during their experience of homelessness. So that's all. Sorry.
Larry? Thanks, Larry.
I've sat in on a couple different discussions of homelessness, and and I heard it tonight, one of the things that is a challenge is that people's needs are increasing, and the complications that they bring to the encounter with the service system is they have much more complicated needs. I think it would be really useful to have a conversation, a structured conversation about how to address the needs that people are presenting. Because, for instance, there should be a way for St. John's to get connected to a service that provides, or can quickly get somebody connected to a service that provides home care or aid care, so that people can can be taken care of. And so the more I sit in on these conversations, I'm very aware that the need level is diversifying, and the capacity of the system to address those complicated needs is very very limited. So I suggest that we figure out a way to have this structured conversation fairly soon.
Thanks, Larry.
Because more and more people are going to be showing up at St. John's and in other places in wheelchairs and with multiple health needs. So we just need to increase our ability to use the resources that exist in the community.
Yeah. So you didn't have a question, that was just a suggestion or an idea?
Yeah, that's my suggestion, that we have a conversation about how to address this growing need. Because there are very expert people who are very knowledgeable about how to address the needs that people with disabilities bring to any situation. I was wondering, for instance, if the person with the developmental disabilities was at all connected to RACR, and the resources that they have. So there's all kinds of things that I think we need to sort of think through.
Okay, Jessica, did you have any questions? Okay. Travis?
I was curious about Serenity House, the number of beds.
Yep, so Serenity House, its initial certification is 9 beds. And then we're in the process of getting that expanded to 12 beds. We have to get a waiver from the city as far as the redesignation.
Length of stay determination?
Up to a year.
Okay.
I had a question.
Oh, good, no, good.
At least a few of you, maybe more, talked about community education and more understanding that would reduce stigma. And I'm wondering, that's probably not a part of your jobs necessarily. So it's just kind of an add-on when you have time. But I was wondering what kind of education you think would be most effective if you've tried anything. Because one of the things that struck me when you said something about of the 40, 35 are doing great and 5 are having issues. So that's very interesting, and I think would go a long ways towards helping people understand that it's not everybody. And, just even an article in one of the papers, the non-paper papers.
Yeah.
I mean, I struggle with the success stories and putting them out there. I'm not part of the Pony Show. It's how I don't want to out our youth as being a homeless youth participant. So we do struggle with that, is, the success stories, and some of them are okay with it. Most of our youth that don't want it out there. So we struggle with that, and getting the positives out, just because I don't want to put it out there that these youth are homeless.
Well, for a lot of human service people, it's just not part of, kind of the job or the whatever you've gotten into it for.
The reality of our community is, unfortunately, we're recipients of the negative.
Yes.
Right? That New York Times article about the jungle has done devastation to our town. Right? So if we have nothing to counterbalance that narrative, right? I've lived here most of my life. Drive down State Street. What's going on in front of Chuck's Mobile? What's happening in front of Jade Garden? What's happening in front of the bank?
Got it.
Where's the encampment in front of Pete's? Like, if we're not having any kind of conversation about this as providers, I don't know how to help the community understand how to get involved, how to understand, but also how to give, so it can be different. I know a lot of people that want to help, and they have zero idea about where to, give time, money, all of those things. So
Yeah.
I hope someday those of us can come together and find a way to help channel some of that.
There's also like a Facebook group that will go unmentioned that is just loves to rev people up about, did you see all the calls to this place and that place? And it just frustrates me to see people just getting bombarded with this information that is so negative, and yet they say they're trying to help. It's like, okay, yeah, that doesn't sound like help to me, but it just, it would be great to have things to just, even little tidbits to put out there or whatever.
I quickly want to say, I'm sorry, I can't see you all, so I just have to jump in wildly. That it is part of my job to work on stigma, so it's something I think about a lot. And information is the antidote for stigma. And when I go out and I give this data and I give you this information, I'm trusting you all with this information as part of the way to reduce that stigma. And we can all do that. We can all counter negative, harmful stereotypes every day. We're faced with many of them. And using critical thinking skills is like the most basic thing that we can all do. So when we're seeing those reports in social media and the scanner group and all of those places that we all are, just sort of activating our own critical thinking skills and asking the people in our lives to activate those critical thinking skills is like just base level fighting stigma. So for the scanner group is an example of that, in that you can see something on scanner group. That's the way that a call came in. That does not make it true, real. It doesn't mean that is the actual thing that happened. That's the way a person in distress called in a police call, right? And just knowing that when you're reading those things and working in your social networks to remind people to use those critical thinking skills is like base level stigma reduction, because it is heavy in our community right now. There's a lot of people who would have never had 10 years ago would not have had any of the information that they believe that they have about these spaces. They were not worrying about them, but now that it's in their face and their doom scroll all day long, they think they're experts. They think they understand what's going on. And so it's people who care about stigma's job to remind our friends and family about those critical thinking skills, that there are people working on this problem, that there is data available to support it, that there are leading practices. They don't have to make up the solution. I think part of what happens is people hear about all these bad things and they think, oh my gosh, nobody's doing anything. Nobody cares. We have to jump into action. We have to reinvent the wheel about, they should go to rehab first and then here. And it's like, we did that all. Our society has already been through that whole journey and landed on housing first. We can figure out how to support leading practices and evidence-based practices. We don't need to go back in time and reinvent those wheels. So knowing the information and using our critical thinking skills is how we can reduce stigma. And also maybe minding our business a little.
Randy, you had something you wanted to say?
It's funny, conversations about, that you don't want to talk about people. And one of the ones I hear from people that are, and myself as well, so it's a bias I have, is where's the accountability for people, right? So and there's a struggle for people to realize that, and I think those conversations should happen. I assume most of you are aware that Thompson County is going to be building a large homeless shelter. How that looks, I don't know, but hopefully your input is put in because and they're talking 100 beds in this big building in congregate type of shelter, and to me that sounds scary. But a lot of But anyways, hopefully that you guys are giving input on that. But one of the questions I have is it smarter to put homeless people in their own little house or in a big building stacked on top of other people? So like you have Suckerman Cottages is a good example. And you're better off building 100 units of 200 square feet so the people have their own home, you know, and they can go outside and they can, what are your thoughts on that?
I think that homeless people are people who have preferences just like everybody else. So some people want to live in a big building with lots of other people, and some people want to live in a little unit by themselves. And I think that being unhoused doesn't change the fact that you're a human person with likes and dislikes like everybody else. And I don't think that there's one program model that fits all. And I think that's why, at least in this community, we have some options, like you mentioned, Second Wind, a steer, like there's a whole menu that if you're lucky enough to have some options, those are good. But I'm constantly reminding myself and my staff that people experiencing housing instability and homelessness are people just like everybody else. They're not this group that just needs something that the rest of us don't need. So I just keep reminding myself, and we try a whole bunch of different models, and some work and some don't, and we just learn and do better the next time.
Anyone else?
Oh,
yeah, I'm sorry.
I have a happy story. So this happened today. So I used to work at the Southern Trades program, and I was the program coordinator for the syringe exchange and the drug checking program and the health was there. And today in the grassy knoll out there, I ran into a former client from the syringe exchange, and he had long-term homeless. I remember giving him a tent and a sleeping bag. And today I saw him and he said he's living at Asteri. Yeah. And he said, look how much weight I've gained. I'm cooking every day. And really, it just made my day. I'm so glad I ran into him, because being in this field, it's so difficult, and you see just like the absolute depths of the human condition, but there are these like beautiful spots. And I'm so grateful that so many of our folks at the Syringe Exchange got housing during the surge, and it was just so great. So I just want to say something positive.
Thank you.
Thank you so much for sharing that story. Thank you.
Yeah, that's a very nice story. We should wrap up soon. It is about 7. But are there any final questions? Did I miss anybody? I want to thank you so much for coming and spending so much time with us. It's such an important topic and one that we discuss a lot. So this has given us a lot more information to think about and to do some planning or action on. So thank you so much.
It was very informative the way it was presented to us today too. This is what we have, this is what we like, this is what we're doing, bullet verbalizing up. So for our board, personally, this is very well done.
Great. Those are my questions. Even though I couldn't remember. Okay, well, we don't have a quorum to do minutes, right? Yes, we'll just do that next time. Everybody's free to go.